If there's one area in critical care that demands constant vigilance and a real global agreement, it's managing acute respiratory distress syndrome in kids' PARDS. For so long, intensivists treating children, well, they had to rely on criteria developed for adults.
Yeah, exactly. And that was, I think, the fundamental issue. Children just aren't miniature adults. Their lungs work differently. The way diseases affect them is different, even how they recover. And PARDS isn't rare. It hits about 3.2% of all kids in the PICU, maybe over 6% needing a ventilator. So
Yeah.
using adult rules wasn't just inadequate. We actually found it was linked to worse outcomes, probably because care wasn't consistent.
Right. A major shift was definitely needed. So today, we're doing a deep dive into the latest guidelines, the second international guidelines for pediatric ARD, or BALI-C2, which came out in 2023. We want to really get into the crucial updates, like how PARD is defined now, how severity is assessed, and the best practices for management, and especially focusing on some new areas like dealing with resource limitations and using clinical informatics.
It was a huge undertaking, truly. You're looking at 52 experts, multidisciplinary, from 15 different countries, all working together to synthesize the knowledge gained since the first guidelines back in 2015. And the outcome, 146 recommendations and statements. It really sets up a new, hopefully more universal framework.
Okay, let's start with the definition itself. For our listeners who are pretty informed, the basics probably sound familiar. Age under 18, symptoms starting within a week of some known insult, new spots on the chest imaging.
Those core elements are still there. But the big change, the really crucial update, I think, is how we stratify the severity.
Ah, okay. How's that different now?
Timing, that's the key. PALI-C2 says very clearly that you only categorize PRD severity mild, moderate, or severe after the patient has been diagnosed for at least 4 hours.
4 hours, why wait? I mean, clinically, those first few hours can be pretty intense, right? Fluids, ventilator tweaks, maybe recruitment maneuvers.
Exactly. That's precisely why. Those initial oxygenation numbers can be all over the place because of that early resuscitation. If you classify someone as severe based on terrible numbers right at the start, you might jump to more aggressive interventions, maybe invasive ones that weren't actually needed. Waiting 4 hours lets things stabilize a bit. It gives a much more accurate picture of the actual risk and helps avoid, escalating care unnecessarily.
That makes a lot of sense. Prevents sort of diagnostic momentum based on initial instability. Okay, so after 4 hours, how do the guidelines standardize measuring that oxygenation severity? Especially since kids might be on anything from simple nasal prongs to full mechanical ventilation.
Yeah, they set up a clear hierarchy for that. If the child is on invasive mechanical ventilation, the preference is to use the oxygenation index, the OI, or the oxygen saturation index, OSI.
Because they factor in the mean airway pressure needed.
Exactly. They give a better sense of how much support is required for that level of oxygenation. But if the patient is on non-invasive ventilation, like CPAP or BiPAP or even high-flow nasal cannula,
Right? Then you'd use the PaO2 FiO2 ratio, or if you don't have a blood gas, the SpO2 IO2 ratio. Those just look at gas exchange efficiency relative to the oxygen they're getting.
and the guidelines also brought in something totally new. Possible PARDS. This sounds like it was designed to catch more patients and maybe make the guidelines more practical globally.
That's exactly it. It's about inclusion and practicality. Possible PARDS does two key things. First, it helps identify those kids on advanced nasal support like high flow who meet all the other pH criteria. They're clearly very sick, but maybe not yet intubated.
Okay.
Second, and this is really important for global health, it applies to patients in settings with limited resources. Maybe they meet the timing criteria, the oxygenation issues, they have the risk factor, but they just can't get a chest X-ray or CT scan quickly to confirm those lung opacities. This category allows them to still be recognized and managed appropriately. So once PRS is diagnosed, confirmed, or possible, the main goal becomes preventing more lung damage from the ventilator itself. VLI, ventilator-induced lung injury. It's that constant balancing act, trying to avoid too much pressure, too much volume, or lung collapse. What does PALI-C2 say about the target for tidal volume, the amount of air per breath?
Well, the suggestion, it's a conditional recommendation, is to aim for a physiological tidal volume, somewhere between 6 and 8 milliliters per kilogram of ideal body weight. That range seems to be the sweet spot for minimizing lung stretch.
But I sense a but coming.
Yeah, there's a crucial remark. Sometimes you might need to go below 6 millikilograms to keep the pressure safe. However, they strongly caution against going below 4 millikilo routinely. That risks significant lung collapse, atelectasis, which can actually worsen gas exchange. So very low volumes need careful consideration.
Okay, that balance again. Volume versus pressure. Let's talk pressure limits. We need to manage plateau pressure, P-plat, and then there's also been more focus recently on driving pressure,
Yeah.
DP, right?
Absolutely. Two key pressure targets here. First, inspiratory plateau pressure, P-plat. That's the static pressure in the lungs at the end of inspiration. The suggestion is to keep it at or below 28 centimeters of water,
Okay.
though you might tolerate up to 32 if the chest wall isn't moving well, like if the belly is very distended. The other, maybe more physiologically important target is driving pressure. That's simply P-plat minus the PEEP level.
Right, the pressure difference that actually distends the alveoli.
Exactly. And the suggestion is to keep that driving pressure, the DP, at or below 15 centimeters of water. High DP is strongly linked to worse outcomes, probably because it reflects the actual stress on the working lung units.
Keeping track of driving pressure means constantly adjusting things, especially PEEP, the positive and expiratory pressure, keeping the lungs open. Did the PALICC2 experts reach a strong consensus on anything related to the ventilator settings?
Yes, and this is really notable. Out of 34 clinical recommendations, only one got the strong recommendation label. Just one.
Wow, what was it?
It's about PEEP. The strong recommendation is that PEEP levels should generally be maintained at or above the levels indicated in the lower PFIRE FiO2 table from the original ARDS network trials.
So, higher PEEP is generally favored. That emphasizes keeping the lung open, recruitment.
It really does. It highlights the solid evidence behind maintaining lung recruitment to fight atelectasis in PARDS.
Okay, so we have a strong push for higher PEEP, but also these important warnings to keep P-plat below 2832 and DP below 15. Doesn't that create a potential conflict? What if raising the PEEP to follow the table pushes the P-plat or the DP too high? Which rule wins?
That's the art of managing these patients, isn't it? The guidelines sort of imply that the pressure limits, especially driving pressure, take precedence. If increasing PEEP makes your DP go over 15, you really need to lower the tidal volume first to try and bring that DP down. If that doesn't work, you might have to accept a slightly lower PEEP level than the table suggests. The ultimate priority is protecting the lung structure from overdistension. Sometimes that means accepting gas exchange that isn't perfect.
Right, structure over immediate function. And that acceptance leads us to blood gas targets and this idea of permissive hypercapnia. Why is it sometimes okay to let the CO2 rise and the pH drift down towards, say, 7.21?
It really is that trade-off. We allow the CO2 to climb a bit, that's permissive hypercapnia, because the alternative is often cranking up the tidal volume or the pressures, and doing that directly risks causing more villi. So we tolerate the higher CO2 to protect the lung tissue. Now for oxygen levels, the SPA2 targets for mild or moderate PARDS, the goal is generally 92 to 97%. But for severe PRs, the guidelines actually recommend accepting SPA2 below 92% sometimes.
Really? Why accept lower oxygen saturation?
To limit oxygen toxicity. High concentrations of oxygen over long periods can also damage the lungs. So in severe cases, you might accept lower sats, maybe down to 88% to try and wean the FiO2, as long as the patient isn't staying below 88% for too long. It's another delicate balance.
Okay, let's shift gears a bit to non-invasive support. If a child's breathing is getting worse, but they're not intubated yet, the guidelines suggest trying NIV, like CPAP or BiPAP, but as a time-limited trial. How firm is that time limit?
They're pretty clear on this. There's a conditional recommendation suggesting intubation if you don't see clear clinical improvement within the first 6 hours of starting non-invasive support.
6 hours? That's not very long.
No, it's not. The evidence suggests that if NIV isn't working fairly quickly, prolonging it just delays getting the lungs properly protected with invasive ventilation. It can lead to patient exhaustion and potentially worse outcomes. So that 6-hour mark is really meant to push for a decisive action. Either it's working and you continue carefully, or it's not and you move to intubation.
Makes sense. Now, what about all those other treatments we sometimes reach for? The adjunctive therapies, things like inhaled nitric oxide, steroids, surfactant.
Right. This is another area where PALICC2 provides some strong guidance, mostly suggesting against routine use. For several common therapies, the evidence just isn't there to support using them on every PRORD patient. That list includes inhaled nitric oxide, or INO,
Okay.
surfactant therapy, which we used to use a lot more,
Mm-hmm.
and corticosteroids. The recommendation is against routine use for all of those. That doesn't mean they're never used, but they should probably be reserved for very specific situations or patient subgroups like maybe INO for proven pulmonary hypertension or steroids in certain viral contexts. It's not a general go-to anymore.
And what about prone positioning, turning the patient onto their stomach?
Prone positioning is interesting. The data in pediatrics is still considered insufficient to strongly recommend for or against its routine use. So it remains an option, something to consider, particularly for patients with severe hypoxemia that isn't responding to other ventilator strategies, but it's not a standard protocol for everyone.
Got it. So beyond the lungs and the ventilator, general supportive care is obviously vital for survival and recovery.
Yeah.
What are the key non-pulmonary recommendations?
Yeah, several important good practice statements cover this. Nutrition is highlighted. Start enteral feeding early if possible, ideally within 72 hours. And aim for a decent protein intake, at least 1.5 grams per kilo per day.
Okay, fuel for recovery.
Definitely. Fluid management is also key. The goal is to optimize oxygen delivery, yes, but with a very clear aim to prevent fluid overload. Too much fluid makes pulmonary edema worse. It's a tightrope walk.
Always.
And finally, managing sedation, pain, and especially delirium is crucial. They really push for using validated scoring tools to assess these things regularly. And importantly, try non-drug methods first, multi-component, non-pharmacologic strategies to prevent and treat delirium before reaching for medications.
Now, this is where PALI-CT2 really breaks new ground, I think. They included two completely new sections. One on using informatics for implementation, and another focusing on global health and resource limitations. That feels like a major step forward in acknowledging the real world of critical care. Let's start with informatics. How can automated electronic tools help implement these guidelines?
Yeah, this is about bridging that gap between knowing the guidelines and actually doing them consistently at the bedside. The recommendations suggest using electronic health record tools for a couple of things. First, for automatic screening. Not just diagnosing PARDS, but identifying patients who are at risk based on specific factors.
Proactive identification.
Exactly. And maybe even more impactful, they recommend using tools for automatic monitoring of whether the team is actually adhering to the PALI-CC2 lung protective strategies.
That's really interesting. Like an alert if the driving pressure stays too high for too long. Does the evidence show that this kind of automated monitoring actually improves patient outcomes? Or is there a risk of just creating alert fatigue for the staff?
That's the million-dollar question in implementation science, isn't it? The potential is huge real-time feedback, maybe highlighting if DP is consistently creeping above 15. But the recommendation is still conditional, reflecting that this is still relatively early days for these kinds of tools in this context. Right now, the focus seems less on proving direct mortality benefit from the alerts themselves, and more on using the technology to standardize care, reduce unwanted variability between providers or shifts, and track compliance.
Okay, that makes sense. Standardization is the first goal. Now let's turn to the global health aspect, the resource-limited settings, or RLS section. This seems like a vital acknowledgement of healthcare disparities. What specific adaptations do providers in these settings need to consider?
This section is so important. First, as we mentioned earlier, it formally validates using that possible PARDS category when you just can't get chest imaging reliably.
Right.
It also gives practical advice on equipment. For example, there's a suggestion that in RLS, if you have the choice between CPAP and high-flow nasal cannula for non-invasive support, you should probably lean towards CPAP.
Oh, interesting. Why CPAP over high flow in that situation? High flow is so common in well-resourced PICUs now.
It really comes down to cost and logistical simplicity, I think. High-flow nasal cannula, while excellent, needs quite a bit of infrastructure, constant electricity, reliable oxygen blending systems, specific humidifiers, the disposable cannulas. These can be major hurdles in some RLS settings.
Okay.
CPAP systems can often be simpler, more robust, maybe use less energy or oxygen depending on the setup. It can just be a more sustainable option when resources are tight. Beyond equipment, the guidelines also make a point that clinicians in RLS need to be really aware of local causes of respiratory failure that might differ from typical Western PICUs, things like dengue fever, malaria, complications of severe malnutrition or dehydration. These can change the whole picture.
A crucial reminder about local context.
Yeah.
Okay, finally, let's look beyond the PICU stay. Survival rates for PARDS are improving, thankfully, so the focus naturally shifts to what happens after discharge, the long-term problems. What does PALI-CC2 recommend for monitoring these kids long-term?
Yeah, this is about taking the long view. They strongly recommend that children who survive PARDS should be screened by their primary care providers for common post-ICU problems within about 3 months of leaving the hospital.
What kind of problems are we looking for?
It needs to be pretty comprehensive. Checking on their overall health-related quality of life, sure, but also specifically assessing physical function, any neurocognitive issues, emotional well-being, and even the impact on the family and social function. The effects of critical illness in PARS can linger or even emerge years later. And there's a specific call out for the youngest survivors, infants and toddlers. They need an extra, more specialized assessment before they start school around age 4 to 6 to catch any subtle developmental or learning issues early. Hashtag ASHAG outro.
So if we try to wrap this all up, the real value of PALIS-CC2 seems to be providing this updated evidence-based framework. It simplifies things like severity assessment with that 4-hour rule, and it's deliberately built to be more globally applicable with the RLS section.
Absolutely. And what really stands out, I think, is the honesty about the evidence level.
Hmm.
Getting high quality randomized trials done in critically ill kids is incredibly difficult. So almost all the clinical recommendations are conditional.
Right, only that one strong recommendation about PEEP.
Exactly, which means these guidelines give us a fantastic consensus starting point, a baseline, but the actual care for each child has to remain highly individualized. You always have to consider the specific child, their underlying problems, their response to therapy.
And that need for individualized care, combined with the conditional nature of the evidence, points directly to the research questions that PALI-CC2 really brought into focus, doesn't it? We've gotten better at the immediate PICU management. Mortality is thankfully decreasing. So the big question starts to shift downstream. The long-term recovery path for kids who survive Pine Arcs is incredibly varied, and the guidelines themselves highlighted that we don't really have good, standardized data on how things outside the medical sphere, like a child-specific demographic background, or, crucially, the social determinants of their health affect how well they ultimately recover.
That really tees up a critical question for you, the listener, to think about. Let's say we follow all the PALI-CC2 protocols perfectly in the PICU. We manage the ventilator just right. The child survives, goes home. What factors then have the biggest impact on their long-term quality of life, their cognitive function, their physical abilities years down the line? Is it access to ongoing therapies, good nutrition at home, family stability, school resources? Understanding that intersection between critical illness, recovery, and these broader social and economic factors, that feels like the next major frontier we need to explore in pediatric critical care research.